2, Region 3, and Region 7. They'll identify the regions that they work for. They're going to introduce themselves. And so what I'm going to do is just take a quick moment for housekeeping, and then we are off and running. So we do have a roster. You've all seen it many times today. Please, if you want any continuing education credits, sign in. And we'll start it right here. Thank you. Other thing is that for the IBM training track, and this is one of those sessions, we are offering continuing medical and nursing education. Instructions are here. If you have not picked up one of these, you can get them on the table. For tomorrow's sessions, same process, but it will be a yellow piece of paper. SurveyMonkey link is there. We ask you to complete it by the end of the week, and certificates will be mailed within, I guess, about a month or so. The actual continuing education for this particular session, you're going to get emailed a SurveyMonkey link, and they ask again that you try to complete that as quick as you can, and you'll get a certificate mailed from Matica within about a month. So without further ado, I'd like to, recording, sorry, knew I forgot something. These sessions are being recorded, so we ask if you could just work with us as much as possible to minimize noise, especially in this quadrant right here. I'm gonna point you all out there, but the microphone is right over your heads.
I was going to say, was it something I said?
So, I think we'll turn it right over to Regional 1 IEN, and there are no conflicts of interest to disclose for any of this session today.
I'm a little nervous all of a sudden when I started. My name is Jennifer Sayer, and I'm the program director for the Service and Resource Center in the southwestern part of the state. But we cover Keene, Monadnock region, and Sullivan County. I am here in partnership with Glenn Lawrence.
So I'm Glenn Lawrence. I'm the program director for Monadnock Family Services, and I'm the co-director of the co-pilot program for this project.
So Glenn and I have been working together and also in partnership with Cheshire Medical Center in the top Keene as a part of developing our Regional 1 IBN project, which is so I'm just going to give a little background on how we got here. So our project is a combination of two, I don't know if most people here are familiar with the IBN project work. So our project is a combination of two pieces, enhanced care coordination and the critical time intervention project. So we proposed in our region to do those pieces together and work in between ServiceLink, Monadnock Family Services, and Cheshire Medical to try to demonstrate how we could enhance and serve people with a mental health issue. It may not be diagnosed yet. Often it is, but our hope is to get people who have a combination of a significant mental health issue, severe, complicated physical health issues, and Medicaid, and help with that transition from hospital back to community, and then also to provide enhanced care coordination for people who fit those same criteria. I'm going to hand this over to Glenn.
So what I would add in terms of that is that the cohort of individuals that we identified were folks that had some significant mental health diagnosis of some sort, often identified in need of services at Cheshire Medical Center. However, referrals also came from the community as well. And we were particularly interested in identifying and creating services to provide services to folks that were falling between the cracks in some fairly significant ways. So the typical consumer that would come to our attention would be someone that had frequent emergency room admissions, frequent hospital admissions, and I think really importantly when we looked at the folks being referred to us, there were folks that were having difficulty adhering to medical advice and medical recommendations, often a revolving door between the hospital and the community would ensue. So our our particular emphasis was on identifying the barriers to accessing appropriate mental health services. Sometimes that was engagement in services generally, so a lot of effort would go into person-centered planning approach to try and engage people, and really try and break the cycle of non-engagement in services. And that varied. It was sometimes, we would sometimes identify that those issues were psychiatric symptoms themselves. If someone has a psychotic disorder or schizophrenia, it may be really worthwhile to just work on relationship building and engagement. For other folks, it was really a skill-based issue. Some of the folks that we have worked with and I think worked with very successfully, it's really helping them organize their lives in a way that they could access services and follow through on medical advice. That might include having one of the co-pilot support workers attend doctor's appointments with people so they can have a really clear understanding of what they needed to do to follow through and to be as successful and healthy as possible.
Yeah, I mean, Glenn basically said it, but I feel like both in terms of transitioning from hospital back to home and people who started in the community who just needed more intensive support, I think we're really, the identifying the systems barriers has been very evident as sort of a big part of what our work is. We currently have 2 full-time care coordinators, and we are actively engaged on the floor at the hospital, which is one of the ways that we're really working to get those referrals, and thinking that we really are planning to move to engage even more with the emergency room going forward.
There are 2 cases that I think are really emblematic of the work that we do at the co-pilot program and how successful it can be. And I'm going to contrast two folks that came into the program because I think their service needs were really quite different and sort of interesting. One is a gentleman that came to us, and at the time of the referral, he was leaving assisted living against medical advice. People were very concerned about his return to the community. He had trouble with ambulation. He had difficulty adhering to a specialized diet that he needed, and he was a fall risk. So when he left services, folks were very concerned. Our approach was to just meet him where he was at. There was no really turning back the clock in terms of his decision to move back home. So the effort was really on trying to talk to him about what services could we put in place to make this as successful as possible. And from his point of view, what would the markers be that would tell him that he needed a higher level of care or that this was not working? It was really important to us that we saw this from his perspective and his point of view. When he left and went home, within a week or 2, he fell. He had 3 or 4 emergency visits to the local hospital within a month or 2. And through trial and error, we were able to identify the things that would lead up to his falls and his difficulties, and he became more receptive to outside services coming in to help him be more successful. So I think that was one of the barriers that we were able to work around. Today he's very engaged. Things are not perfect. He fell, I think, several weeks ago, but he is leading a successful life in the community, and it was really clear to us that his decision to leave assisted living and to return to the community was overall a really sound one and one to be honored and respected. And we had worked with him to try and make this work as successfully as possible and to honor the dignity and risk that kind of came about with that service. In terms of how are they doing?
We have about 8 minutes.
Okay, so the second contrasting case is a person that a few years ago there was a a delay in misdiagnosis of a cancer of the eye. It was really troubling. We weren't there at the time to understand all of the particulars in terms of what happened, but she lost eyesight in that eye. That is very concerning. She already had fairly robust mental health services through MFS, so connecting her with mental health services is not so much the issue, but it's certainly trying to help her negotiate the medical system was. And what we found in doing so is that without continual advocacy and really rather important systems work, including some consultation with legal services to make sure that her services were being, her medical services were as good as they could be. We were finally able to get her the assistance she needed. And one of the things that concerned us in this case, and it concerns us across the board, I think, in Copilot, is there's a stigma attached to mental illness. And when people are in the emergency room or being treated medically, there are times when people's symptoms and concerns are really getting clouded by their mental health diagnosis, the way that they are treated. And in some ways, and this is where partnering with the medical community is important, clients with severe and persistent mental illness can be confusing reporters of symptoms. So I think being there to partner with people to try and explain that in more detail is something helpful. So I think in those two cases, we feel pretty good about the work that we have done with those folks in particular.
So I think the only thing I would add is that I think Copilot is also in part about the bridging communication between systems and how technology is going to be used to have our project interface better between these existing services, and hopefully in doing so provide better communication, better sort of planning advocacy for the person, but also have less duplication between these systems. So that's, I think, as most of you involved with IDN work are aware, that's part and parcel of this work. And we are definitely embedded in it, and we are sort of also bringing together different Medicaid-funded work in the hopes that we can sort of streamline that as well. So some of the people we work with are on the Choices for Independence program, we are also figuring out how to bridge those care coordinators with our care coordinators, which I think is not always a simple thing to do, and I think we've had some real success so far. So that was the only thing I wanted to add.
Good.
I think we can pass it on.
Thank you. Hi, I'm Kate, and I'm a facilitator. I'm not a random audience member, just jumping up and grabbing the microphone. Because we are recording this session, if you guys have questions, what I'm going to do is I'm going to stand up in between each session, just ask if you have questions. Then I'm going to run the mic to you so you can speak into it so we can hear your question, which will be intelligent and wonderful. Does anybody have questions right now for the Copilot team? Looks like no. There will be another opportunity at the end of the session to ask questions of all the folks here once you've heard of them. Oh, thank you.
You mentioned using technology to bridge multiple providers. Can you say a little more about how that's working?
Sure. One of the things that we are working on right now is the shared care plan. So that's an initiative that we're rolling out. I think that one's fairly interesting. So, for instance, I don't know if folks in the audience are aware of shared care plans. I think this has been initiated across the state to greater or lesser degrees. So, an example would be if someone comes to, say, the attention of the emergency room, rather than multiple calls going back and forth to try and coordinate care, there's a shared care plan in the shared care portal, and it will address both the likely physical needs that folks would be wanting to consider when someone first comes into the emergency room, in addition to whatever behavioral issues that might be in play. So if someone were to come to the emergency room and we are aware, because we know the person, that they would be frightened, suspicious, maybe a little paranoid about the care providers, that we could, number one, be dispatched pretty quickly to be part of the admit process, but we'd also be able to give them valuable information in terms of what they would need to know to work as effectively as possible. And that information would be shared amongst several providers. Cheshire Medical, certainly, if it's an out-of-area physician, might do that. Could be another emergency room, not necessarily connected to Cheshire Medical, so that we have good coordination. And it would also be basic things like medications. If it's someone that we have concerns about overdose or drug misuse, that information would be readily available so that folks have a very clear idea of their needs. Is that specific? Thank you.
And I think I'll just add that part of what got us here is that we need to develop business associate agreements between the partners, and so that's took time, obviously, and it's been critical to us being able to have a more common sharing of patient information and with the patient's permission. So there are many elements to that, and so it's sometimes feels very slow going, but it is going. And the way Service Links really got to the table with this was because we have staff on site at the hospital already, so the hospital had been sending referrals to Service Link via a platform called e-discharge. I don't know how many hospitals in the state use it, but that's, so I think ideally in the long run, all of our partners would be communicating through these same electronic mechanisms with the same HIPAA compliant agreements.
Yes, and on we had our family services, and we are rolling out a few different things. One is a medication assisted program and an in-house doctor that will be providing services linked in through Cheshire Medical so that folks can be served right within NFS.
Thank you. All right, and we are at time for this group. And again, good job. Thanks, guys. And again, we will revisit this at the end, so there'll be an opportunity to ask additional questions. All right, and next we're going to come down to Mary Ann and hear about Region 2 and choices for families.
Hello, my name's Mary Ann Evers. I'm an MSW. I work currently for Waypoint, New Hampshire, which recently we just changed our name from Child and Family Services of New Hampshire to Waypoint. So I've been there for a short time, but I've spent a lot of years in my life working in both what I would call child protection services as well as outpatient mental health. And I've been involved in a lot of projects over the years that are an integration of those things, and it's the thing that's most near and dear to my heart, which is kind of why I got involved in this whole thing, which has been an interesting bit of a journey. So I'd just like to start by saying, telling a little bit of a story, which I see somebody in the room here who knows all the real stories, so she's going to know that I'm coming up with a bit of an amalgamation of stories. So. I'll just cop to that right up front. So I'll tell a story about a woman, I'm going to call her Sue. She's a 28-year-old woman, and she's had 5 prior pregnancies, and she comes to Enhanced Care Coordination, which is this project, Choices for Families, referred by her MAT provider. She's about 8 months pregnant, she's just coming into treatment, and she's had all 4 of her previous pregnancies have resulted in removals, so kids have gone to foster care and or various relatives. But this particular pregnancy, she ends up in medication-assisted treatment, and she is, and her partner, interestingly, of about 10 years, same father for all 4 children, or this being her 5th. And she and he are committed to making this pregnancy different. So this is, they're at the time living couch surfing, I think we call it, so pretty unstable housing, and they come to us looking for supports around helping them with this new baby. So that is a story that is, oops, sorry. Did I do something? Oh, no, there it goes. This is kind of a typical story of the families that we get involved with. Oh, hang on. And I'll just say, how do I do this? Okay, technical difficulties. Okay, sorry. All right. I'll say that Choices for Families is the name of the program that, it took us a little time to come to this name. We started out, we are actually a collaboration between 3 major, or actually 4 partners, and that would be Riverbend, their substance use disorder treatment, which they call themselves Choices. We work with Dartmouth Hitchcock and Concord OBGYN, the PAT providers, where they're providing medication-assisted treatment to pregnant and parenting women in those 2 facilities. And then our particular program, the Enhanced Care Coordination Program, is a collaboration between Waypoint and NAMI. So we have a lot of different kinds of, I think I'll just start by saying that one of the original kind of challenges for us is having so many sort of different points of view about how to work with families, and then how to sort of bring those points of view together to create a program that would understand and best serve the family. So we're still not able to get out.
If you could just say advance, I'll advance it.
Okay. So what is, so a little bit about that. Enhanced care, if you can go to the next one. Enhanced care coordination. What is the objective of enhanced care coordination? I guess simply said, we're just trying to engage families who are pregnant and parenting these very young children in services that will help to mitigate their exposure to multiple adverse childhood experiences and result in more positive health outcomes. I'll say that if you were to ask maybe the medication-assisted treatment providers, their objective might be just a little bit different than ours, in that they were just really primarily looking to help people get stabilized in their, I wouldn't even call it recovery, more in their use, so that they can have a healthy baby. So you could advance it, okay? The sort of framework that we use in social services often is the protective factors framework. And are people familiar with that framework? It's pretty well known and well researched, that if you look at various factors in families' lives and build on their strengths, you can help increase the kind of positive outcomes that we're looking for. So when you're looking to do things like, you're looking at parental resilience, for instance, we're kind of trying to figure out how families who have dealt with issues or crises in their past kind of use those experiences to teach them about how they're going to learn and react to their, to new circumstances. So at the very beginning, when we first got started with this project, we were targeting almost everybody under the age of 6 with any kind of mental health or substance use issue. The target population included families with history of trauma, substance use, or serious emotional disturbance, as well as pregnant women receiving medication-assisted treatment. We had the same kind of partners that we currently have, which is NAMI and Concord OBGYN and Dartmouth Hitch, Riverbend. Also, props to UNH Institute on Disabilities, who really are the ones who have coached us through a system of learning how to use the New Hampshire wraparound model, which is the model that we use for enhanced care coordination, and then Concord State Hospital as well. So we had this rather wide, and we had a target, the biggest target I guess here was the very small children, so we were looking at preschoolers. But the kind of risk factors were extensive. So what we found when we first got started was that created a bit of a problem in terms of, well, what is it exactly that you're doing in enhanced care coordination that's anything different than what everybody else might be doing, other RAC models. And as we started to look at that, we realized that really we wanted to narrow. So we kept kind of narrowing. Yeah, our next one. Oh yeah, that's good. Thank you. We kept narrowing our target population so that we could really work on our referral system, and that meant moving more and more closely towards working with the medication-assisted treatment providers, so that anybody that they had, that they were working with, providing medication for, that we were doing everything that we could to connect with those women so that we could connect them with their enhanced care coordinator and their family support specialist from NAMI to help them kind of look at their concrete needs and then try to help them move into this RAP process, which I'll talk about in a little bit. Basically, what we were charged with doing was working with 10 families per year. So it seemed that we had one person, one enhanced care coordinator, and one family support specialist that was going to work with 10 families, which didn't seem too tough of a thing to do. But at the beginning, it was slow going. There weren't a lot of referrals. And I'll talk a bit later about how that's gone, because we've really come to find out it wasn't that hard after all, and we ended up with more and more referrals, which is a great thing in some ways. So how will we get referrals? We had, I'm sure if anybody in here has had anything to do with the IBNs, you would know that working in a project like this involves about 5 million meetings. And so you're constantly meeting and trying to figure out what everybody is doing, and a lot of learning is going on across a lot of programs. Next. So here are some of the outcomes that we anticipated with our enhanced care coordination project. Normal birth weights, that was a goal. Connection to concrete supports like helping people find housing or jobs or employment resources, or getting them on Medicaid or that kind of thing. We saw ourselves as getting involved in safe plans for babies discharging from the hospital. We wanted to connect families to any supports that they need, and to connect back a bit to the protective factors. We want to improve their parenting capabilities by helping them learn about child development or about parenting. We use something called the protective factors survey to pre and post, kind of keep an eye on whether people's ideas about parenting have shifted over time. We hope to support and sustain recovery, and as I said before, we wanted to serve about 10 families. The next one. So here comes the good part. What were the challenges? This was one of the things we were asked to talk about, and I can tell you that the first real big challenge was in engaging people. Other people, I think, spoke about that as well. If you're homeless and you are, which a fair amount of our people are, and you're in a state of crisis, the first thing you're thinking about is not, when am I gonna sit down and engage with my enhanced care coordinator? First of all, what the heck is that? And secondly, why do I need it and what is it gonna do for me? So we really worked really hard to figure out how to engage people. And I have to say that working with a person, working with NAMI, who brought to the table a person with lived experience, does a lot towards helping to engage these very difficult to engage people. So anyways, the challenges were multiple and a bit daunting, and they went everywhere, as you can see here, from legal issues. Lots of these folks, not surprisingly, have pretty serious legal issues associated with their drug use, a fair amount of domestic violence, very poor, most of them, and a lot of multi-generational DCYF involvement. And basically, you had people that were feeling pretty burnt out by their experience in working with others. Geographic, hurry up. So one of the first kind of interesting things we came across was geographic challenges. So when we first started this project, we just said, well, we'll go anywhere in the state, because we're going to work with the MAT providers, and the first thing we found out about them is, lo and behold, in Concord, the MAT providers are providing treatment to people all over the state. And in fact, they're usually not from Concord, they're from somebody else. So we started going all over the state to meet with these people, and that was a bit of a challenge to kind of get out there and know all the resources. So I'll just quickly say that we have, it's important to note that the approach that we use is this New Hampshire wraparound care coordination model. That's the next slide. And this is supported through UNH. And this is, if anybody's heard of Fast Forward before, it's a evidence-based wraparound model where you basically learn, you help a family go through a process of identifying their strengths, their needs, and their vision. And it's a family-driven process. And the intention here is to work with people who are a bit different, who want to give a different experience than what they've had before, in the hope of really helping them move forward and accomplish some really important changes. So I'm going to move ahead a few more because I want to kind of get to there we go. So if you can go back to the one. All right, that's great. So here is the crux of the model. This model is all about, first of all, it includes a long period of engagement. So you're allowed, according to the model, to take up to 4 or 5 months to actually engage somebody. I mean, that's pretty unheard of these days, to have that ability to do that. While you're stabilizing somebody, you're kind of helping them with their concrete needs and helping them connect with them. Then, as time goes on, what you're supposed to do is help them move through this process of identifying their needs. And if you can see here in this slide, the kind of needs that people are helped to articulate. I mean, even though their stories are dramatic and really sad and hard to witness, their needs are not unlike anybody else's needs. In this one, she needs to know that I'm not alone, and I need to feel secure, and I need to know that I can parent both children successfully. So getting people to a place, people that are in this sort of life condition where they can articulate this kind of their needs, and then conversely to move on to the next slide, to identify a vision for themselves, is really an amazing kind of process to be a part of. And these visions are the things that are held up by the family as where they want to get to in life. And then the team of the enhanced care coordination, the job of the team is to help the family understand how to get there. And keep having them look at their vision and what is it that they're doing to help them get to this vision that they've articulated. And I'll just say couple more things. And then a quick thing about our outcomes. As I said before, we were supposed to see 10 families in a year. We had a total of 38 referrals in the past year, and
So I don't think we have time for questions, right?
Maybe one.
Maybe one? Awesome, we have time for one question. Great, we only have one kind. Sorry.
So you mentioned there's one family with DCYF. How has that gone? Like how involved is it? It involves children. So can you talk a little bit about how DCYF is involved?
I'm gonna try to be diplomatic here a little bit, but I would say that I think we've had 5 women who've given birth in the time since we've had this program. And we've had and each one of them ends up with DCYF involvement. But the nature of that involvement and the way in which things go is very hard to predict. And it has a lot to do with the individuals that you kind of end up getting from the system. But we've worked really hard to figure out ways to make that better. So we're working very closely now in a partnership with Concord Hospital and making that better and better so that we can have team meetings with DCYF to coordinate these discharges in a way that leaves children feeling being safe and well taken care of and supported.
We're gonna go right ahead. We're gonna pass right on to Marie. Go right ahead.
Okay.
Yes, we're. And now, yay.
My name is Norima Sidania. I'm a psychologist with Greater Nashua Mental Health Center. I have a doctorate degree in clinical psychology. I used to work with children and adolescents, which led me to substance use, which led me to Greater Nashua and becoming their coordinator for the IDDD team. Now, this project, this IDN project, the IDDD team is the Integrated Dual Disorder Treatment Team. Now, the outcome for dual disorders is poor. We can see from relapse of mental illness, treatment problems, hospitalizations, violence, victimizations, homelessness, incarceration, medical problems, family problems, and overall an increased servicing cost and use. So IDDT, so traditionally, treatment for co-occurring disorders was to treat the disorders separately. Could be parallel or it could be sequential, but it was not, people with mental illness would not really get the care they would need for their substance use and vice versa. So let me go to the next one. So this model, the IDDT model, offers to have an intensive integrated treatment for both mental illness and substance use disorders. So most of our clients, I should say all of our clients actually have severe persistent mental illness occurring with very severe substance use disorders. So I would like to talk a little bit about the team because this is all about the team. In the past, you had several providers, different offices. With our team, it's one team, one location, one meeting. We all do things together. So we are a very close-knit team, and that's how we take our approach. Our providers have transdisciplinary training. So though I'm a psychologist, 2 of my staff members are therapists and 2 are case managers, the model called for transdisciplinary. That means that I'm going to do case management. If one of our people needs to be run to the doctor for a urine test, I'm going to do it if nobody can do it. And all people are trained to have clinical training to have the ability to do interventions while they are with our clients. So it's bringing a team that can address the need not only for mental illness, but also for substance use and helping clients to just be able to engage more easily within our system. Some of the problems that we meet with our population, like Marianne was mentioning, is that we work in a mental health community center, so our population are 60% homeless. They are not going to want to address their substance use issues or mental health issues if they don't have shelter, food, protection. So part of our treatment is that we meet the clients where they are. And that includes being working with intensive outreach. We are always in the community. are going to meet them if they are at the shelter, we'll be there, and if they just want to be able to talk about anything, be it about, a long week today, or if they just want to spend time with us and have a cup of coffee. That's how we're able to engage them. We really meet them where they are. And our treatment is stage-based. So the stage of treatment. And people who are just in contemplation, engagement, not sure if they even want to talk with us, well, we go to their house and we try to keep engaging, say, listen, it looks to me that you might need some help with housing. Let's help you. Let's go to DHHS and fill out the paperwork. Let me help you with Medicare, because that's a bear to just, it's very daunting for our clients, all that paperwork. So we sit down with them and we help them. That helps to build that therapeutic alliance. And then they are able to just say, okay, if that person can help you with just helping you with getting food, then maybe I can talk to them a little bit more why I started to use and what my fears are. And I'm going to let them in a little bit into my little world. So right now we are a team where we have what they call in Germany. And I still carry a case of about 15 people while providing supervision for 4 other people. We have 4 clinical case managers who are providing case management, FSS services, therapy. We also have a support employment specialist. We have a psychiatrist and a nurse on the team. And all those roles are very important because the case I'm going to talk about really started with our support employment specialist, which might seem the less important person on the team if you want to see the role, because people who don't have shelter don't always want to just even go to work. They might not even be able to function enough to go to work. But we'll come back to that when we talk about the case. We have a ratio. The ratio is important. We are supposed to serve about 10 to 15 people per member of the team. Right now, it's a little higher because there's high demand. And, maintaining employment, keeping our people to stay with us, it's a tough population, it's a very intense job. It's going to be a little bit of a challenge to say, hey, why don't you stay a whole year with us? It's not always easy to get people to stay in community mental health. So this is a small ratio. We are hoping to hire 1 more person to bring back the ratio to 10 to 15 clients per provider. So why that approach? Because it works. Research has shown that it's 50% more effective than previous treatment. So over time, it takes research has shown it's about 3 to 5 years to see results. Depends where people are really on their journey to recovery. If they are a little bit earlier in contemplative engagement, it might take a little bit longer. But if they are they are good incentive to just attend to their treatment, then it can take a little bit less time. I would like to talk about my case. Our case, actually. So we have a client who's a 49-year-old female who was divorced. And the divorce came because of her substance use. She lost her children also into that divorce. It was drugs. She started with an affair with a drug dealer, and it just went downhill from there. Her husband was in the military. He took the children, and it just really, for her, spiraled out of control. She could not maintain employment due to her severe alcohol use. And twice in 6 months, she ended up going to a job, being drunk, and getting laid off, which really let her spiral out of control for her own self-concept, not being able to have her own housing. So she was referred to us from our substance use department, but she could not attend IOP, she would still come to session drinking, and so she was referred to us. She had severe depressive disorder, she had severe PTSD, she could not go without drinking during the day. She was referred to us, and she bonded with our employment specialist. And not that she was trying to find her job, but she was talking about her past experience with job, and what worked, what didn't work, and they really formed a bond. And we also started to work with other providers in the community. And that's something that we do. We are very open to refer our plans out for different IOPs. So she ended up going to an IOP with a different provider, going to treatment with us, and the communication, which is very important amongst providers, was excellent. So when they would call me and say, you know, she came in today, we're pretty sure she had been drinking, then it would be, you know, great for the meal, and we would talk about it in session. At some point, when she came to IDTT, we started to work with her as a team. She had the case managers who helped her to just try to go around the city to get more a hand on the paperwork, documentation, cards, such things. With us, she started to work also with the the employment specialist, because she did need the money at some point. She wanted to move out of her house, where she lived with her sister. And she started to realize that her issue was really impacting her life. We would meet with her almost every day, which is really a privilege to be able to do this, but every member of the team was able to do this. She ended up going to Farnham, and she was able to stay the whole month. Now, this is a woman who had been to AdCare, who had been to any kind of treatment, stay a week and say, I'm done, I'm leaving. She could not just stay, of course. With the support of the team, she was able to stay through the Farnham treatment. And she said, because I have a team who believes in me behind, you know, and she would refer to us as her team. So it becomes family. It's really that feeling, you know, of we're here for you. When you get out, we graduate with you, you know, it's all together. She was able to come out. She went to live into sober living. And from there, she was able to get employment. And she was able to maintain employment and to stay sober. So there's still hurdles, you know, there's still hurdles. And some of the hurdles is, yeah, it's nice, but how long can we maintain through her recovery that support, the scaffolding that we have been doing? And on the road through this part of treatment is going to be able to help her to become more independent. And you're going to have to go to AA meetings, and you're going to have to do this on your own, but we'll be there at the beginning. Then let's try to find your sponsor and just do a very gentle transition to other helpers in the community. So this has been, took a few months, but has been an unusually fast recovery, of not recovery yet, but treatment. And I think we need to be a little suspicious about quick changes like this and keep an eye open, but I think it's also very encouraging to see that a treatment team approach that is integrity, that is intensive, can bring such high results with clients who have been given up by other providers. When you see severe mental illness and severe substance use, a lot of providers don't want to get involved. I mean, even in our own company, they were tossing her around, saying, who wants her? And she qualified to be with us. But it's lucky that we had this program, that it was created. And I think that it's important because we're helping to fight the stigma that I meet every day in other providers, that we see people that we serve as primarily being addicts, not suffering from a mental illness. And it's such a relief for our people, for our clients, when we acknowledge you have a mental illness, you suffer from a mental illness, you suffer also from substance use. I don't see you just as an addict. And for them, it's refreshing. Some people breaking into tears. So, oh my gosh, you understand. Yeah, I do. So I think that this approach, this integrative approach, working with the community, not only is a great way to send a message to our clients that we understand them, but also send a message to the community that there's a stigma that we need to erase little by little. I'm done. Unless I'm done. Yes.
It's amazing. The timing was excellent. Does anybody have any questions for Lorraine? No? Just gonna let it sink? Every time somebody moves something. Okay. All right. We're going to move on now to Annette from Region 7.
I'm going to find my PowerPoint. I'm Annette Carbonell, and I'm with the North Country Health Consortium in Region 7. So how many here have heard of the North Country Health Consortium? Yay! It's not always been the case, so it's really nice to come down country. We are in Littleton, New Hampshire. And this, if I get the right button, there I do. So who are we? We're a little different than some of the organizations that have been presenting here. New Hampshire Public Health Network. We are also the lead for the IBN Region 7, the administrative lead. We are Northern APAC, which is the Area Health Education Center. So, am I still working?
Yeah.
Okay, sounds good. So, and as you can see, there are other things that we do. We really look to meet the unmet health-related needs of people in the North Country. And if you look at the dark green section, that is the area that we function in. So our project is about care coordination, working with community health workers. So I wanted to start at first, because a lot of times when I talk about the program I work with, which is community health worker, people say, what is a community health worker? The definition you see on the screen is a national definition that public health looks at. And I really think that the piece to focus on here is that they are a liaison between the patient and healthcare and social services. They are a bridge to these things. And they can go by many names. Community health worker is someone that works in community health. So some of the folks that have talked about their projects here, the folks that are doing some of this work are falling under the umbrella of community health worker. Positions like care coordinators and patient navigators. There's a lot of positions that fall under that umbrella of community health. So the other point I wanted to make before I tell you a little bit more about our program is, and we've all talked about this, and I'm sure I am preaching to the choir here about social determinants of health. And that it is clearly understood that really healthcare is responsible for the health, only about 20% of your health. And that the other 80% are social determinants of health. And these are really important things when you think about, as others have talked about, food insecurity, housing, heat, where you're going to sleep the next day, and even things like socialization, and who you're going to talk to. There's a lot of pieces to social determinants of health. So this is what our program focuses on the most. So ta-da! This is the Ways to Wellness Connect program. So our program, we looked at the fact that there was a lot of unmet needs for people in the North Country over 65. So this program was developed to meet those needs. So what we do is we link community health workers to patients with unmanaged chronic disease that are 65 and older. And actually we're going to be able to do it with a slightly younger population. The work that our community health workers do is patient-driven, and it's really patient-driven because if the provider says, we need you to work on their blood pressure, but the patient says, I can't work on anything until I figure out what's wrong with my dog because it's the only companion I have, or until I figure out how to move out of this house because I hate living here with the people that I'm with, we need to focus on what's the most important, the barriers that the patient sees or the client sees as most important. So we're non-clinical. We don't do anything clinical. We don't take blood pressures. We don't give out medications. We don't do anything that is clinical. But what we are is the eyes and ears for the providers. Because we meet with clients in their community, in their homes, and we see and hear many things that never happen or never get revealed in a provider's office. I'm sure most of you have heard of white coat syndrome. Well, we all go to the doctors and we want to be the best that we can be when we're there, and which is the opposite of really what we should be doing. So the other thing that's really unique about our program is that the North Country Health Consortium is a non-clinical place. So our community health workers are being deployed from a non-clinical base to hospitals and primary care offices that we have agreements with, BAAs and MOUs, so that we can exchange information about their patients. And so they come from ours, we receive a referral, and they're referred to go work with the client in that region. And we go all the way to the tippy top of the state. So our approach to care coordination is a little different. It's not quite as traditional. It's more about life coordination. Like I said, there's a lot of unique barriers that can get in the way of people getting well or seeking help. Because we meet in patients' homes and in their communities, we learn so much more about them than you would in an office. We also, our community health workers, are people that are living in that community, experts in the community, have connections in the community, and that enables them to really provide appropriate resources. We focus on the social determinants of health. We stay in our lane, and that's really important and really hard to do. Any of you that do care coordination, any of you that do patient care, probably all of you here. Staying in your lane is really difficult, but we've developed a program with very clear boundaries. And we teach to fish. Our ultimate goal is that these folks are going to be independent and that we can step away from helping them. That doesn't mean we can't step in later, but we want to help them become more independent. So instead of doing one case study, I'm just going to throw some names out at you and just give you some examples. And they may seem really small to you, but let me tell you, if you knew these people and I've spoken to them, these things are life-changing. There's Rosie. Rosie wouldn't accept help from anybody. She'd had many strokes, she needed a walker, her husband had died within the last 6 to 8 months, and she was independent, North Country, don't mess with me, and I don't want you in my house. And I won't say the other things that she said, because she has got quite a repertoire of language. Finally, a community health worker she accepted just to meet with him once. And we have men and women that do our community health work. And John went in and he met with Rosie. And to make a long story short, what was the largest barrier to Rosie was that her husband, he had served in the military for years. And then he went on to serve in the police force up north. And he was in the sheriff's department. And he died, and she could not afford a cemetery plot or a stone. And it just wasn't right, because he had served his entire life. She was not going to take any help. She had to find a way to save money and make this happen. Again, long story short, John connected her with some veteran organizations, police departments, etc. The next thing you know, a plot was donated, a stone was donated, and Rosie felt like, as others have said, I can ask for help. Hey, this is asking for help is pretty cool. I can do this. Now Rosie has home health, and she has Meals on Wheels, and she has somebody that brings groceries and fresh food to her house, and she's happy. She still swears like a trucker, but she's happy, and she's healthy. Jane's story is very simple. She was referred to us to have a community health worker go check on her because her thyroid numbers, which were supposed to be under 10, were over 100. Jane said, yes, I picked up my prescription. They called the pharmacy. Yes, she picked up her prescription. The nurse said, do you have it? Yes, I have it. This went on, and her numbers got worse and worse and worse. In fact, I don't even know how she was walking and talking with that kind of number if you have a thyroid condition. And the community health worker, Amber, she goes to the house. Guess what? Seems there's a problem with getting the bottle open. Nobody had she told for months. She went to the pharmacy, she picked up her prescriptions, she put them on her counter. They were all there unopened. She didn't know she could have the cap reversed so she could unscrew it. She didn't, she was too embarrassed. Then there's Matthew. Matthew had Parkinson's, some dementia. His wife had passed away. And he was really struggling with being house with some other people who had the downstairs who were somewhat caregivers, but he really struggled. And he was treated with some medications, and a community health worker developed a relationship with him, and Matthew seemed to get more and more despondent, more and more depressed, until one day when Amber went to visit him, he said, "There's logging trucks go down this road constantly, and I'm just going to walk out tonight in front of one. That's it. I'm just going to end it." He trusted her with that. And she said, because she'd been trained, she knew what to say. Bottom line, she connected him, got services. He needed the medication change. Right now, Matthew's happy, very happy, and his adult daughter and him are both very grateful that he's still around. And then there's Jackie. Jackie wanted to gain weight. She just wanted to gain weight. She was uncomfortable. She'd been sick. She felt lousy. She didn't want to talk to the world. She was too skinny. This was her problem. This was what was on her mind. John went and worked with her and started talking to her about, well, maybe eat an apple with some peanut butter. Well, first he checked, of course, with the nutritionalist at the hospital, made sure everything was going to be what she would like and what was healthy for her. And he worked with her, and she said, "I'm only going to see you once. You either do miracles this first night, or that's it. You're done." And he went back, and she invited him back, and she invited him back, and she gained weight, and she started going out with friends. And I'm very sorry to say that 3 months later, Jackie passed away because there was a cancer that took her very quickly. But those last 3 months of her life, she kicked butt. She was out there having fun. She reconnected with her family, which she hadn't felt well enough to do, her daughters and son. And finally, there's Robert. Robert had been in the ED so many times for over-medication and under-medication. Come to find out, when the community health worker gets to his house, he'd been keeping all his different medications in these little bowls on the counter. So he just helped himself to some red ones if he was supposed to have the red ones, and helped himself to blue ones if he was supposed to have the blue ones. You can imagine. He was on things like Coumadin. It just got out of control. We don't give him his medication. The community health worker works with him to learn how to set up his pill box every week. And we went from bowls to little bowls to drug boxes to post-it notes to he's been on target for the last 3 weeks. This just gives you an idea of the types of barriers that all of us here may think are very insignificant, but we have watched these people bloom and grow and become healthy, overcoming both physical and behavioral health issues. And as my time is running out, I just want to mention 2 things, and one is sustainability. These are some ways. Right now, we are sustained by a grant. We are looking forward to sustaining community health work. There has been a lot of projects around the country that have proved return on investment. And then there's also opportunities for reimbursement through Medicaid if community health workers become certified. And there's going to be a shameless plug here in a minute that I'm going to give for the New Hampshire Community Health Worker Coalition, who is coming together and working on certification. And I'd love to have you grab a brochure before you leave at the end of today. Accountable care organizations, obviously they're incentivized for triple aim, higher quality, better outcomes, saving money, and community health workers do all these things. And you can see at the bottom there's a couple examples of, and there are many, many more, where community health work has, as you can imagine, saved a lot of money in the long run. And we look forward to the future. We currently, in the last year, from September to September, we had 104 clients that we worked with. And if anyone is interested in learning more about our program and getting CEs, again, shameless, there's a brochure here and a little business card, which is a webinar you can take online to learn all about our program. And thank you.
other questions right now? Yeah, great. Let me bring you the mic.
This is about the IDDT team. What do you think are some of the barriers and how can we help address that with the workforce? You're saying it's hard to get people to even stay a year on your team. You know, if the treatment works, that's great, but if you don't have the people to give the treatment, people aren't getting what they need.
Great question.
So what we have done is that we have been becoming very discerning about who we hire. It takes a little bit of longer time, but we hire people who are more qualified, people who are more, let's say hire for character, transfer skills. Well, that's what we are doing right now. And so at the beginning, we went through our growing pains where coordinators left. We had 4 coordinators before. And they were essential within the team, and some people were not qualified, didn't have the training. So we work with a consultant, an identity consultant. I'm on the phone with him once a week. And we have been doing this now for about months. And we've been working toward building better protocols, and I just hire better people. And one thing I do with my team really is that when I do supervision, it's very important to us that we do whatever we can for clients. We said, what can we do for you? You work so hard. Don't tell me just for the paycheck. What can I do? What can we do to make it worth your time? Something for you. Somebody said, I want to learn rope. I just want to learn rope. I said, fine, let's get to the training. We can start by being a co-leader or co-facilitator on some of our groups. But I always try to find the thing that are going to make them tick. If you can make your team happy, they'll stay. And sometimes it's not about the money. It's about, are they happy with what they're doing? And do they feel good in the team? And do they want to be part of this group? And so that's what I focus.
Did anybody else want to address that question? Anybody else have any share? Does anybody else have questions? Any questions? Do I? Okay. Okay. That's terrifying for everyone in the crowd.
I just wondered, is the goal of all of these programs to eventually spread out into other parts of the state?
Anybody want to tackle that? That's a big question. Anybody? Yeah. Sure.
I mean, absolutely, that is the goal. I think the first goal is to demonstrate that the projects are worthy of being spread, and we're still kind of working on that. Some have more dramatic kind of stories or more compelling stories than others that will bring forward more funding. But yeah, that's the idea. It's good, we'll spread it.
I think it's about showing the need. In New Hampshire, we definitely have a need for all those services. But it's also to show the founders that we can sustain ourselves in the long run, because we cannot just depend on grants. So this is also a big part of what we are doing. We are prototypes, and we are pilots, and we are showing, working hard to show there's a need, we are meeting it, but we can also make it last a long term.
I would hope that the community health worker program would spread. It is. We currently have over 100 members of the New Hampshire Community Health Worker Coalition, which is working to build the name and the understanding of this position. This is a healthcare workforce shortage option. This is a solution to bring people in to be able to provide these services and allowing others to work at their licensure level. I know for us in the North Country, we are moving forward on working with community health workers and recovery coaches in a warm handoff model because we are also part of the consortium is the Friendship House, the treatment facility in Bethlehem, New Hampshire. And we are moving forward to use community health work in the same kind of model, working with people that are in need of treatment and recovery. So yes, but we have to prove that it will save money. That's the bottom line.
First of all, when I was thinking about the North Country, someone said it's only slightly smaller than the Louisiana Purchase. I remember that. So I can't imagine how you serve that. Yeah, that dates me. I learned in history class. Seventh grade. But when people were talking about social determinants of health, and I think people know this, but working with people with severe and persistent mental illness has just become my life mission. So some of the statistics that I think about, folks with major mental illness die 20 years on average sooner than people without. Diabetes, congestive heart failure, spinal stenosis, stroke, all of these things are just terrible problems. I mean, it's not because the healthcare is not out there to provide the service. It's if you're homeless and if your priority is getting through the day and figuring out where you're going to sleep, then clearly that's not going to be your priority unless there's someone in your corner championing your cause. And I don't want to be overly critical of the healthcare system, but I feel like I've had to spend 30 years fighting the healthcare system to make sure that clients that we serve are well served and are taken seriously. So that's I think an important mission. It was so nice to hear this throughout this panel. And I think it really is important. It's hard enough when you don't have someone in your corner. Having had elderly parents and a family with some resources and the fights it took to get appropriate service, then it is just so much harder with our population. So there are some wonderful healthcare providers out there. So this is not an adversarial statement. It's simply working in partnership to make sure that our folks are well served is not an easy task, but it's an important one. That's the reason.
Thank you for not throwing that. I thought you were going to toss it. Any other questions? No? Is it my turn? Yay. Sorry, I was hoping. And then not at the same time. One of the things that we've kind of spoken about, we had some pre-panel calls, or pre-panel call. One of the things we talked about at that time was how different New Hampshire is, right? Considering the North Country, which we've talked about, but then, looking at the Seacoast, looking at, the Nashville and Manchester areas, the center of the state, which is where I'm from, Keene, it's all really, really different, right? What are do you guys have any regional kind of considerations that you took into account concerning these programs? Does that make sense as a question? Yeah.
I would say,
I'll go to Annette first. I'll go to North Country first, right? Yeah.
I would say, and this may be the same for everywhere, but maybe a little bit more for us, is like things like transportation just really pop out as my first answer. I'm sure I can think a lot more, but if you don't have transportation and you can't get, the 20 miles to the doctor's office or the 30 miles to the pharmacy, or maybe it's only 5 miles, but there's nothing really walkable. Our population is spread out, so providers' offices are spread out and hospitals are spread out, and less services are often offered because there's not the population to support them. So for some of those reasons, yes, an elderly couple that lives at the top of the state needs a lifeline.
Oh, sorry. I think that for us it's a little different because we're so in the trenches, we are outreach, so we can go to people's houses. And a team as a doctor, as a nurse, so we are pretty self-sufficient even within the agency. So we don't have some of the limitation to be in anywhere in the state. So this model, IDTT, all over the country has shown that it was sustainable, it worked in different settings, rural, urban. So I think we are just in a very privileged position.
I think I just want to add that I think the question was sort of the things that we took into consideration, and I think in the southwestern part of the state, I'm not originally from New Hampshire, but I have in the last 20 years become a huge advocate for the southwestern part of New Hampshire, being sort of out there and very rural and very North Country-like in many ways. And I think we needed to take into account caseload size, and that it is very different when you live in a rural area, and really I'm not sure how. I think it's often misunderstood how rural our state is, and that you can't expect the same caseload volume for people, for case managers, care coordinators, etc. So I guess I just wanted to sort of add that piece to it. I also think technology is a very different story if you're in the southwestern, northern, or different pockets of the state mountains.
Right. No cell service.
No service. Route 9 to
I think the thing I think about in terms of what we took into consideration, I think of the general vicinity of Keene, and we certainly work well beyond that. And your point about this being a rural area makes sense to me. My wife and I have lived here since 1989, and I came to MFS last year, and I'm embarrassed to say that I did not realize that the trails that I was jogging on with my dog, where people live, homeless camps, so homelessness is a huge problem. The bike trail where I would ride bikes on is a common place for people to shoot up because it's close enough to the police department that they realize that there's greater success for being saved by Narcan. So these are just really sobering things that I think is an important part of what co-pilot and co-pilot-like programs be helping with. In addition to sort of a proud rural population that is embarrassed and has trouble reaching out around healthcare issues. We've had a few folks living with their elderly parents, and they have been, for very understandable reasons, feel like they're really the care provider for their 85, 90-year-old parent. So our ability to get in the home and help people realize that there are resources out there to lighten the load for them. And sometimes it's engagement in private, sometimes people really didn't know what services were out there to help them. So I think that's an important piece of things.
Temperature check. Any other questions? I get to go again. Something else that we talked about, something that I've heard kind of reflected throughout this panel, I think, is in each of these situations, these very different projects, there's some commonalities, right? And I think one of the loudest commonality that I heard was that you have staff that are able to just be really, really flexible in how they deliver services and what types of services they deliver, right? So my question is, what has been the biggest aha moment for you guys regarding having a staff person who's able to just be really, really flexible in how those services are delivered? What was did it move a big barrier that you were surprised about? Did it cause an outcome that you didn't expect?
One of the benefits of the RAP model is that it comes with flexible funding, and that has made all the difference in the world to people. To be able to, I think of one woman who, these folks are pretty much living on the margins, and she had a job, she was working at, I think, Project Mountain, her car broke down. If we could give her the money to get her car fixed, she could get to work, she wouldn't lose her apartment, and her kids wouldn't end up in foster care. It's not the end all of the story. You need to, help people think about how to predict those issues when they can and to plan better, but to just have access to just when people need a little cash. Sometimes that's what they need. So that's really
I think for me, I'm always in awe of my team. You know, I'm like a proud mom. But you know, for me, I'm always amazed and humbled when I see one of my people just say he needs to get to front of him Franklin, and he has to be there for 7 o'clock in the morning or 8 o'clock. I'm going to take them. And I have to tell them, I say, listen, we're not a taxi service, maybe we can just try to find somebody to give a ride. No, he knows me, he'll be comfortable with me, and I can help him de-escalate if he gets nervous during the trip. So it's that kind of going the extra mile without even being asked. And some of them don't even ask for their mileage reimbursement. I have to push them every month. Did you do your expenses? It's a lot of money, you should do it. But I'm always amazed by that dedication. I think it's true in every person that works in mental health care, just not being serving the population we serve. That dedication, that empathy, that motivation, that is really a mission. It's a calling. So I'm really grateful for that.
I would just say that the staff we have, excuse me, is incredibly flexible, but I think that the boundaries that we set in there and have them stay in their lane also provide them with the structure that they need, so they can be flexible, but they know it won't be expected to go on and on and on. And I think we've been so fortunate to hire just people that care about people. And the training, we do community health worker training at the consortium, the training that we do, it all falls into place. But like you said, it's the people, it's the staff. You're working with people that really care about people. And for our program, often you need an advanced degree to help people in the way that they are. And the community health worker program provides an opportunity for people without advanced degrees to follow their heart and be able to help people in their community.
Yeah, so I echo everything people said, but I would just add that I think I've been, I feel sort of honored over this last year and a half of doing this project that we've also had some turnover, things change, and what I really feel like is people, it takes special people. We have some special people who are care coordinators for our team right now, and even when you come up against a time when you realize, I don't understand why that other person thinks that way. I don't understand why the hospital social workers do that. I don't understand why, whatever it is out there, that people who are willing to stick with it, ask the question, and be respectful and kind. Not only amazingly so to people who are homeless and really struggling, but to other providers. And that is a big problem in our healthcare and social services system, a lack of mutual respect. And I feel like the people we work with, well, Glenn and I sometimes argue, but other than that, the people who work with us are pretty amazing. Kate only
knows that. Now everyone knows. Yeah, so our shout out is to Rebecca and Stephanie. They're in the audience and they just do amazing work. So I presented these cases, but I was not the one sitting in the monitor's office with this poor woman who is getting conflicting information about whether, oh, maybe your eye is fine, the MRI looked okay, but maybe this is metastasized to the other eye. We'll try and schedule you, send her to Concord, and they, there's a long wait. They send her home. They weren't the ones sort of sitting with that tension and the emotions that must be generating. So that, at that ground level, it's pretty amazing what people are able to do. So they're really kind of the heroes of the program. Just sort of spokespeople.
Thank you guys, it's great. How are we on time?
About out.
We're just about out. Hey, we did it.
Working it out.
All right, can we do just one last round of applause for both these guys? Thank you guys for being people who care about people. So, all right, we release you to the rest of your day.